Hello, future PTAs. I hope you guys are doing well. Today we will talk about genetic disorders. So there's various categories of genetic disorders. The primary two are chromosomal abnormalities, and then the other is specific gene defects. So under chromosome abnormalities, there's non-disjunction, which is where the cells divide unequally. There's deletion, where part or all of a chromosome is lost. There's translocation, where part of a chromosome becomes detached and reattached to a different chromosome. Under specific gene defects, some are autosomal dominant traits. That means one parent has the gene, or the gene spontaneously mutates to become changed in that way. If it's autosomal recessive, then a parent is a carrier for the disorder and they have the gene, but it's not expressed. So they may or may not know that they have that gene. When you have a sex-linked inheritance, those traits are inherited by, it's an abnormal gene on the X chromosome. So remember, females have two X chromosomes, males have an X and a Y chromosome. So if a female gets a sex-linked disorder, then they can carry it without any symptoms. If one of their X chromosomes is normal and only one is defective. If a male has an X chromosome defect, then they will display the disorder because they only have that one X chromosome. Down syndrome. So now we're going to go through several genetic disorders and just a basis for what they are. Basic explanation. So Down syndrome is a genetic abnormality. It consists of an extra 21st chromosome. So it's been coined the term trisomy 21, 3 chromosomes on the 21st chromosome. One risk factor is advanced maternal age. So an older mother, as she gets pregnant, is more likely to have a child with Down syndrome. Some of the features are low tone, joint hypermobility, flat feet, scoliosis. So those are all some things that we may see and treat in the clinic. They also typically have a congenital heart defect that may or may not cause them to have a surgery or multiple surgeries sometimes. They may have issues with feeding, issues with hearing, and with vision. They often have specific facial features that have been called mongoloid facial features that are common. So it's a flat nose bridge, narrow eyelids, small mouth, which is one of the reasons that they have feeding disorders or issues with feeding, especially latching on when they're young. And another common characteristic is like a wider neck and then a larger tongue. Often the tongue will be protruding, especially if they're concentrating, working really hard on something. There are some intellectual disabilities associated with Down syndrome. Typical IQ is somewhere between 25 and 50, and they typically are slower to develop their motor milestones, and the life expectancy is a little bit shorter than the average, around 60 years, but still a pretty long life expectancy for a genetic disorder. A few of the things to think about with Down syndrome when you're working with them for physical therapy, take into consideration the fact that they may have heart disease, they may have a heart defect, so you may not want to overwork the heart or overexert them. You want to emphasize exercise, stability, respiratory function. A body weight supported treadmill might be a good option when they're first learning to walk. Orthoses might be a good option. It just kind of depends on their needs and their stability level and what they're able to do. One thing I have noticed with Down syndrome is what the parents focus on the most is what develops. So I've had children where they focus a lot on the motor skills, but maybe not as much on the ADLs. And I've had some that focus a lot on speech, but not as much on reading or a lot on the schoolwork, but not as much on the independence with potty training and things. And I have seen several children develop at way different stages in each of those categories, just depending on what they focused on. I've seen some potty train way earlier than others just because it was focused on, but that same person may not have developed speech as early because it wasn't the focus. So I have noticed that in my own practice that whatever the parents choose to really focus their attention on, the child usually makes significant gains, but it's sometimes um, it's kind of at a detriment to something else. It's like you can't win at everything. So that's just a side note that I've noticed. All right, Crudiche syndrome. This is an intellectual disability. Crudiche means like a cat-like cry. So oftentimes as an infant, they'll have this really high-pitched cry that's really characteristic of this syndrome. The eyes are typically spaced out more wide, and the head is typically smaller, and they typically have low muscle tone and congenital heart disease. With Prader-Willi syndrome, obesity is common. One reason is because they just constantly desire food. So, limiting and putting boundaries on that might be important. They typically have short stature, even smaller hands, smaller reproductive organs or gonads. Low tone, typically have a mild to moderate intellectual disability. Speech therapy is often needed to improve feeding. Um, just keep in the back of your mind that speech therapists work on feeding as well. So not just on speech. That's really key in a younger population, especially in infants when they're not latching on, or in children who have sensory problems and they are not able to tolerate certain textures of foods. Speech therapy is great for that. And then aerobic exercise is important for these as well. Prader-Willi is caused by a deletion of chromosome 15. And one of the other symptoms they often present with is coordination impairment. So between, weakness, coordination impairments, and obesity, there's several things that we can help with as far as physical therapy. Arthrogryposis, I'm probably not saying it right, multiplex congenita. Just a minute. The sneeze is coming. And now that I said it, okay. All right, I'm going to just sneeze randomly. I just feel it coming. Sorry. It's a non-progressive neuromuscular disorder thought to occur during the first trimester of the pregnancy. Some think that it's because of restricted space within the mother's womb or the uterus that causes fibrosis of muscles and the joint structures. It could also be caused by an autosomal dominant trait or by developmental issues that cause poor movement during early development. So one of the big signs is minimal fetal movement. And they typically are born with multiple contractures. They may have joint dislocations when they're born. They may have muscle atrophy. Their arms and legs are typically more tube-like, less defined areas for muscle or for joint. They typically do not have cognitive deficits. But primarily, the goal in physical therapy is to get more mobility, to decrease those contractures, to help with positioning, with range of motion, and to work on walking. A lot of children with this diagnosis actually walk around 18 months of age, so not very delayed. So a pretty good prognosis for that. Osteogenesis imperfecta, this is known as brittle bone disease. There are 7 subtypes. Primarily, you want to educate the caregivers on positioning and handling, and I will say be very, very, very careful with this population. I personally had a PTA I worked with that was trying to do some range of motion and stretching exercises with a child who had this disorder, and the main characteristic is they fracture very easily. I mean, they could just be sitting in a chair and fracture. I mean, they could have a fracture with no known cause, no whatsoever. So, um, a few weeks after they'd been doing physical therapy, they were found to have some new fractures, and the parents sued the physical therapist, saying that they felt that they were the reason they had the fractures. Now, we don't know what caused the fractures, whether they were old or happened, they could have maybe happened. So you just have to be very, very careful, very gentle, very careful, because the slightest pressure could cause a fracture, and you absolutely don't want to do that. And you also don't want to put yourself in a bad situation. So educating the parents on positioning and handling. You can do a little bit of range of motion and strengthening, just be very careful and very cautious. Working on functional activities that may or may not be able to do some gait training. And then orthotics and medical management is really, kind of where you would direct a lot of the treatment towards. Cystic fibrosis, this is an autosomal recessive disorder of the exocrine glands. So it causes a defect, it's caused by, a defect of the 7th chromosome. And it causes the pancreas not to secrete enzymes that help break down fat and protein. So those fats and proteins are not being broken down as they should. It causes the mucus to be abnormally thick. It builds up in the lungs and produces a lot of respiratory complications. There we can do, for as far as physical therapy, some chest physical therapy to break up some of that mucus and help with postural drainage, maybe some gentle exercises, but understand that it will be difficult for them to breathe, period. And so you don't want to really push them over the edge, where if they're already in a deficit, and you're creating more of a deficit by causing them to need more oxygen. So just be careful with that. Often their life expectancy is shorter, and their ability to reproduce has been questionable. In the past, it was said that people with cystic fibrosis could not reproduce. However, most of them did not live long enough to try. And recently, the life expectancy has went up greatly for people with cystic fibrosis because of different, medications and treatments. And so they found that some can have children. So it may or may not affect the reproductive system. Spinal muscular dystrophy. This is an autosomal recessive disorder. It causes progressive degeneration of the anterior horn. Okay, the anterior horn cells in the spinal cord. That's where the motor neurons are. Some types are related to a mutation of the 5th chromosome. There are typically 3 different types that they explain. The types all have very similar symptoms. However, they show up at different stages in development, and they are different in their speed of progression. So the first type is acute infantile. So it shows up typically within the first 2 months of life. And unfortunately, the life expectancy here is very low, less than a year for most children with this, up to 2 years tops typically. It might be important to help educate the parents on positioning and things like that. But there's not, a cure or something that's going to delay the progression. Type 2 typically shows up a little bit later in their early stages, within the first few years of life. They may survive into adulthood. It causes a lot of proximal weakness, so that's like your shoulders, your hips, and scoliosis is very common in people who have type 2. Type 3 is the slowest progressing. It typically does not show up until ages 4 through 17, somewhere around that age. They often will be able to live into adulthood. And it is, of course, the least invasive because it shows up later in life and progresses more slowly. So some of the symptoms that are present are muscle weakness and atrophy, diminished or absent deep tendon reflexes. Typically, they will have normal intelligence, so that's not affected. Their sensation is typically intact, but they often have respiratory compromise, end stage, so significant respiratory compromise. So this could lead to the shorter life expectancy. Duchenne muscular dystrophy, symptoms typically begin between ages 2 and 5. It's a progressive disorder. It's caused by the absence of the gene that is required to produce proteins that help build your muscle. So the proteins that you aren't able to produce with this are dystrophin and nebulin. And this causes the cell membrane to be destroyed along with myofibrils, which leads to loss of muscle contraction. So eventually, fat and connective tissue replace that muscle, and eventually, it can cause death because of cardiac failure because your heart is a muscle. So, that would be what would cause when your muscles are stopping from being able to contract, then the heart will eventually stop contracting as well. So typically, cardiac and pulmonary failure will happen by age 25, often younger than that. It is an X-linked recessive trait, so it only manifests symptoms in male offspring. Female can carry it, but typically does not demonstrate or show any of the symptoms, at least for this type of muscular dystrophy. There are other types that affect different populations. It causes a progressive loss of strength and function. Again, the weakness is typically more proximal, shoulders, hips. Causes some range of motion deficits. Waddling gait is a very common symptom. They may require orthotic devices. They may require surgeries, definitely adaptive equipment as it progresses. So in the picture below, you see the child is walking with a good gait pattern, and then the weakness causes gait abnormalities. Eventually, they'll need assistive device to walk, eventually leading to wheelchair mobility and in the end stages, power mobility. So it is progressive in the loss, and as physical therapists, we may be able to slow the progression just a little bit or to be able to maintain some of the movement and function that they have, but that would be our main goal there. Becker muscular dystrophy, these symptoms typically begin around age 5 to 10. The life expectancy is a little bit longer, into the 50s. One of the main things that we want to do as PTs is just promote fitness and decrease weight gain in this population, just because anytime you have muscle weakness, the more weight you're carrying around, the harder that is. This one specifically affects the pelvis and the hips first, which is a little bit different than Duchenne's muscular dystrophy. And that's all I really care for you to know about that one for now. Fragile X syndrome. So this presents with cognitive deficits. So the IQ is typically between 20 and 60. They typically have gross and fine motor developmental delay, a waddling gait, tactile defensiveness, meaning they kind of pull back to touch. They don't like touch. Sensory integration problems, increased joint mobility. Some of the facial features that are common are an elongated face, large protruding ears, and a prominent jawline. So they have also those physical symptoms that are common with Fragile X. Rett syndrome, this is almost exclusively in females. It can cause intellectual disabilities, ataxia, growth retardation. I had a patient who was diagnosed with it that was able to walk, but she had significant tone in her hip flexors and in her hamstrings, to where she had a very significant crouch gait. And sometimes, again, they may go through stages where they're able to walk, and others where they need power mobility or a manual wheelchair. But it can affect them cognitively and their motor function. Huntington's disease, this is also called Huntington's chorea because it is characterized by chorea, which are those involuntary rhythmic types of movements. It is a neurological disorder that is characterized by degeneration of the basal ganglia and the cerebral cortex. The neurotransmitters become deficient and aren't able to help modulate those movements. It is autosomal dominant, and typically the symptoms are not seen until somewhere between age 35 and 55. So even though it's dominant and is more likely to be passed on to your children, most people have already had their children before they ever have their first symptom, and so they don't know that they're passing that on to their children. It could cause personality changes. It can cause ataxia. And later in life, it also often causes mental deterioration, depression, problems with speech and swallowing, incontinence, immobility, rigidity. So you can imagine if you go from being an independent adult to losing the ability to control your bowel and bladder, or the ability to walk, or the ability to feed yourself, how depression could certainly be associated with that. Epilepsy, we don't exactly know the cause of epilepsy. It feels like there's a lot of things that contribute. It is a chronic condition. It's characterized by seizure activity. It's caused by temporary brain dysfunction related to hypersynchronous electrical discharge of cortical neurons. So the neurons in the brain are firing excessively. A seizure is a symptom that brain function has been interrupted, and it can look a little bit different. Typically, looks like they could lose consciousness or just awareness of their environment. Typically have some movement disturbances like twitching or um, uh, quick involuntary movements. Sensation may be lost during the time, and mental function may be changed during the time. So they're not responding to you. It's typically when they come out of it, they're very tired, confused, disoriented. Typically, it is controlled medically. There are medications that can be given. The unfortunate part is a lot of these medications are very strong with very serious side effects. So it's, something that parents have to really take into consideration when they're thinking about starting a child on this type of medicine. The other thought is there are surgeries for extreme cases of seizures where it is significantly affecting their quality of life. There are surgeries that can damage certain centers of the brain to stop the seizures, but then there's also brain damage involved. And so there's some significant side effects related to that as well. Epilepsy is more likely in children with genetic disorders, or if somebody has had head trauma, or someone who has dementia or has had a stroke. It's also more likely in people who have cerebral palsy, Down syndrome, and autism spectrum disorder. So a lot of the populations we've talked about in this slide or in this PowerPoint are more likely to have epilepsy. Our last slide, typical PT impairments. With all of the genetic disorders we've talked about, there may be some psychomotor development issues, which is not necessarily a PT impairment, but something to consider when you are educating patients and when you are developing a treatment plan. There is often low tone, which is basically generalized weakness, delayed postural reactions, which would lead to balance problems and coordination problems, poor postural control, which will delay their motor milestones, like having trouble sitting or standing independently, contractures, skeletal deformities, and problems with respiratory function. So you want to be very careful not to overwork this population, as they may already be in some respiratory distress, and you certainly don't want to push them over the edge. All right, so we will talk more in lab, and I will see you in the next lecture.